Hi, everybody. I'm going to do a quick wrap up this week on your acute kidney injury. I'm going to just talk about the case study real quick. You did an excellent job on that. But remember, so I'm just going to give you a few key pointers on acute kidney injury and make sure that you understand the most common causes. And if we look at the case study, this lady had multiple risk factors for her, the reason why she has acute kidney injury. She has prolonged hypertension, risk factor, heart failure, lack of perfusion, cardiac perfusion, therefore a lack of possibly renal perfusion. She is an elderly female, she's 78. But although female versus male does not matter, she has those multiple comorbidities. She's on diuretics, most likely has a history of heart failure, although it doesn't say. Actually, it says prolonged history of hypertension, heart failure. She's had open heart surgery in the past. She's symptomatic, and as you might remember, her potassium was high, so she is retaining potassium. Those kidneys are not filtering correctly or adequately, and she's has an increase in creatinine. Those byproducts waste are not being eliminated in the urine like it should because they're not perfusing. So for chronic or acute kidney injury, remember what the most common causes are. Would be diuretic therapy. So that gives me a red flag as to why all of a sudden she has an acute kidney injury. Her volume is too low. She most likely has hypovolemia. She's puffy because she's third spacing with that fluids. If you remember, go back to pathophysiology. Blood pressure is low. If it's low, your body and organ tissues are not going to be able to perfuse. Sometimes medications can cause acute kidney injury. Sometimes surgical procedures or going through recovery post-surgically, you can have acute kidney injury. Infection, or sometimes contrast dyes. So you have to, really look at that creatinine. So this goes beyond now thinking into nursing care. Let's say a patient has a CAT scan ordered with contrast. Now we know contrast can cause acute kidney injury. It has an effect on the kidneys with filtering. Even in a healthy person, we know that. But you have to make sure that you get a creatinine and a GFR, glomerular filtration rate, which is a common measurement now that we use to determine how their kidneys are filtering. The other thing that I want you, just a little tidbit, is that you can have chronic kidney disease and have an acute injury on top of chronic kidney disease, because you can be stable kidney disease stage 3, let's say 3B, then you can have an acute kidney injury on top of that and then bring your GFR down dramatically, and then that needs to be treated. So this patient, most likely, this acute kidney injury is multifaceted. So she has heart failure, she has hypertension. So now it's compromising circulation to the kidneys. And so then what's going on? There's a decrease in cardiac output that can damage the kidneys. And when we look at pre-renal, intrarenal, and post-renal, make sure you understand what the differences are. But this patient, this acute kidney injury is caused from pre-renal issues. So basically that tells me it's external to the kidneys. So what does that mean? She has heart issues. All right, so it's not directly an issue with the kidneys, but she has a decrease in cardiac output because she has heart failure. Remember that left ventricle is not pumping out the blood as it should. And therefore, you're not having good filtration, good perfusion, I should say. The other thing is, remember, the urine-specific gravity is elevated. The patient has some CAS in the urine. So that tells me that it's oliguria of an intrarenal failure caused by acute tubular necrosis from ischemia. So one thing to think about with this is that although this is a pre-renal cause, this can lead to an intrarenal issue, a chronic kidney issue. This patient is clearly in the oliguric phase, and make sure you review what the oliguric phase is, diuretic and recovery. What are some, now let's go beyond. How do we know she's oliguric? You're looking at this patient's labs and you're like, oh, okay, well their urine output is lower, potassium's high, the patient could be tachycardic, and other electrolytes are imbalanced. So that tells me that this is probably in the oliguric phase, not yet diuretic, and not yet to the recovery phase where your creatinine then peaks and then drops down to normal or near normal levels. And how are you going to diagnose this? Renal ultrasound, renal scan, a CT that can check for obstruction. An MRI, renal biopsy. Let's see what's going on with the arteries. Why is your kidney not perfusing? And then let's talk about nursing diagnosis. So there's multiple nursing diagnoses that take place here, but some of it is excessive fluid volume. You have to look at the patient's overall status. You're doing your situation and background. So that's going to help you with your assessment. This patient has excessive fluid volume. So what do you need to do with this patient? So this patient most likely has to go on a little bit of fluid restriction. And if the creatinine, if the patient is an acute kidney injury and you're not able to conservatively manage it with fluid restriction and possibly diuretic therapy. Again, it's a fine balance with diuretics. There's no really right answer. It's tailored to the patient. So it's a balance between, did she get too much diuretic? Did she not get it? Does she need more diuretics to get that extra fluid that she has on her? But we need to, the kidneys aren't filtering, so she's obviously retaining toxins, correct? So her creatinine is elevated. We notice that by electrolytes. And so sometimes we need to send patients to dialysis. So that's when they put in the catheter that you watched on the other video for chronic kidney disease, and they have that temporary and dialyze the patient, whether it be one time or two times. Again, it just depends on the patient, how the patient's going to respond. You're also going to make sure that you are adequately giving them the right nutrition. So you're doing more of a moderate protein. Because remember, if you have too much protein, it needs to get through the kidneys, and your kidneys aren't going to be able to do that. Potassium, phosphorus, you need to monitor that. And the one thing, remember with potassium is cardiac abnormalities. That's so important because it's a major determinant, a risk factor for patient to go into ventricular tachycardia or other cardiac abnormalities. So foods high in potassium, what are they? Bananas, oranges, potatoes, spinach, tomatoes. Foods high in phosphorus. Remember, these patients now are retaining phosphorus. So you want to avoid phosphorus foods. So it's processed foods, milk, nuts, chocolate, dried beans. So make sure you know the dietary restrictions and what you would give the patient. I know we all probably dread those types of questions on NCLEX, but unfortunately they're going to be on there. And as well, what's really important is that you can really treat a patient and maintain their kidney function well, especially if they're in early stages of kidney disease. I know I'm going over to chronic kidney disease, but you could maintain their kidney function by diet. So it's so important. And the goals for conservative therapy for this patient that we are talking about is to eliminate the cause. So what's going on? Manage the signs and symptoms, prevent complications. So how are we going to prevent complications? You're going to dietarily give them what they need, make sure their nutrition balance is fine, monitor their electrolytes. If they need calcium, you're going to give them calcium. If you need to restrict their potassium, you're going to restrict their potassium. If you need to give them K-exolate for the potassium to bind in the gut, so you can eliminate the potassium to go down, that's a possibility too. Or do you dialyze the patient? And that is it on acute kidney injury. Also, make sure that you understand what the rifle criteria is and what stage of acute kidney injury the patient is in also.